Well, good afternoon, everyone, and welcome to this Parkinson's Academy webinar. My name is Nigel Hastus, and I'm the head of the Parkinson's Academy and the chair for this afternoon's learning. A huge thank you to our sponsors, Zambon UK Limited. Without their support, we wouldn't be able to provide this afternoon's learning. Our first session will be from the award-winning Parkinson's team based at the University Hospital of Derby and Burton, discussing multidisciplinary management of Parkinson's. So, without any further delay, I will ask Rob to start this afternoon's session. Rob, over to you.
So thank you very much, Daiga, and thanks for inviting us to talk. And I hear there are plenty of people joining us today, so hopefully multidisciplinary care is a topic of interest to everyone. This webinar is really going to be a team effort. I'm going to kick off with some principles of team working and give some examples of different types of MDT in the care of Parkinson's. And then Claire's going to talk about psychosocial aspects of Parkinson's care. And Fiona is going to round things off with an outline of some of the roles of the different team members. So when I explain Parkinson's to someone newly diagnosed, I often say Parkinson's is due to damaged dopamine neurons, and levodopa will top up the brain's dopamine supply and make you feel better. And while that is true, it's not the whole story, because lots of symptoms do not respond to levodopa, and medication of all types may be limited by side effects. So offering a range of drug and non-drug treatments to address both biological and psychosocial symptoms may be the way forward. So this is a diagram from Bastian Bloom, and you'll see that multidisciplinary care is one of the 4 pillars of care. And the multidisciplinary team can also help with education to help towards an informed patient and informed caregivers. So what makes a good team? Well, this is my opinion about what makes an effective team. I think in Parkinson's care, it's important to have a shared understanding of Parkinson's, and then to develop shared goals with the patient for their benefit. I think face-to-face communication with team members is really important, and I'll say a little bit more about that later. Respect for each team member is important as well, and we can learn from the skills of other disciplines. And of course, attention to results, not just to the process, is an important factor. So some other ways of looking at MDT working. I think it's important that we treat the patient as a whole person, not just movement or not just anxiety, but have in mind the whole person and their social support network. And bear in mind that the person with Parkinson's is always at the centre of care. I've already discussed that psychosocial factors are as important, if not more important, than some of the biological factors. And of course, when we're designing a rehabilitation program, it's important that we set realistic goals. So do MDTs work? Well, of course, there's plenty of evidence out there that multidisciplinary care for Parkinson's is effective. And I'm going to draw on just a few examples of different types of multidisciplinary team working. So in Holland, Bas Bloom set up a service called Parkinson's Net, which is pretty much nationwide. He set up regional networks of motivated specialists, and the specialists had to go on training courses. So there was a sort of kite mark of expertise. And another key part of Parkinson's Net was transparency of outcomes. So each service that purported to be specializing in Parkinson's committed to publishing outcomes such as emergency admission rates of Parkinson's patients and hip fracture rates. So I think this is not really like the service we have in the UK, but I think there are some things perhaps that we can learn from that approach. So the service that we run in Derby includes a weekly multidisciplinary clinic, which has happened just this morning, which is why I look a little bit older now than in the photos you're seeing. And the different team members in our service include geriatricians, physiotherapists, OTs, speech therapists, dietitian. We've got a consultant in mental health, and we've got a consultant palliative care doctor who comes once a month. We have access to psychology services and dietitians as well. So we're lucky enough to have quite a big multidisciplinary team. At the weekly clinic, we undertake standardized assessments. One thing that we've been doing for very many years is postural blood pressures and heart rates. And we also do a number of other standardized, both objective and subjective questionnaires. Bone health assessments have improved over the last couple of years, and these are led by the RGN in our clinic. So we have shared documentation, which is now electronic, and after the clinic we have an MDT meeting. Newly diagnosed patients get a call from our Parkinson's nurse so that counselling about the diagnosis can be given in a timely fashion. So the weekly MDT meeting is face-to-face, and shared information about individuals information is shared about the cases that we've seen in the clinic, and the treatment plan can be adjusted with input from other team members that are at the meeting. And of course, with different experts in the room, we can learn from each other. And I've certainly found that having a mental health expert in the room has added to my learning and my skills in managing people with Parkinson's with mental health problems. And trainees that come to our clinic get a chance to present their cases and get advice from other people in the room. There's also an opportunity for team building, because we obviously, when there's ever a multidisciplinary team meeting, there's shared cups of tea and cakes, etc., which help with bonding. And we all get a better knowledge of what different team members have to offer. So sometimes patients contact our team during the week with questions, and there's a chance then for whoever's fielded the call to present that situation to the team, and that might result in a call back to the patient or an expedited clinic appointment or possibly a home visit. And over the last year or two, we've expanded our home visiting service. The PD-COP stands for Parkinson's Disease Community Outreach Project. So our Parkinson's fellow and the PD nurses go out regularly and see patients in their homes. So that's our service in Derby, and this is a different service. Jory Fleischer runs a service in Chicago. She's a neurologist, and she's a movement disorder specialist, and she's worked with just a small team, a social worker and a nurse. And they've gone out to people's home. They've visited people with advanced Parkinson's, and they've taken history, examined the patient. They've focused on medicine's reconciliation, and they do a psychosocial assessment to make sure social factors are attended to. And then they come up with a plan. And people with Parkinson's were satisfied with the service. And of course, because this is a progressive condition, UPDRS scores tended to decline, but quality of life was maintained. And Jory has published further data about her service, and she's actually shown that certain symptoms can be improved with this kind of approach. So the last type of multidisciplinary service I wanted to draw your attention to was an Italian service where they've done inpatient rehabilitation for people with Parkinson's. So in this service, they invited people with Parkinson's for at least 10 years and who are at stage hernia at least 2.5 to 4 to be inpatients in their service. So these are quite advanced patients, and this is what they did whilst the patients were in. They were admitted to a rehab facility, and they had 90 minutes of task-oriented physio per day. So quite a lot of physio. They had 30 minutes of CBT twice a week and 30 minutes of OT once a week. And all this therapy was individualized rather than given in groups. And the outcomes were that there were improvements in UPDRS score of 25 points. So if you compare that, for example, to the UPDRS improvement you get with deep brain stimulation, this exceeds the improvement that you might see with DBS. Obviously, the patients, the suitability of patients for these different types of treatment is going to be different, but it just gives you an idea of how big the improvements were with this kind of treatment. And the cost, whilst expensive, is certainly comparable to insertion of a DBS device. So, of course, if you're thinking about how thinking your MDT doesn't look like any of these MDTs, well, in some ways that's not surprising. You have to start from where you are, and you have to build on what you have already. And of course, if you've got a small service, then you need to recruit transformation managers or commissioners or interested colleagues to help build your service. And it needs to be built little by little. And remember some key principles. Education is really important for the patients and the carers, as they have to self-care for 99.9% of the time. We're only helping them for a very small part of their year. There are plenty of guidelines out there, and following guidelines helps improve the service that you provide. Parkinson's care should be person-centered and holistic, and teams should have good communication and respect. So I'm going to stop there. I'm going to hand over to Claire.
Hello, hi, I'm Claire. I'm the one of the specialist occupational therapists in the team. So I'm going to concentrate today on the biopsychosocial model of work that we use here in the Derby team, but also focusing a bit more on the role of the OT. So most views of what occupational therapists do around the country is around kind of ADLs and aids and equipment. But in the world of Parkinson's, that's not always the most appropriate. So obviously we look at ADLs, we look at other areas of intervention, bed transfers, driving, seating, upper limb, all of those sort of things. But today I'm really going to concentrate on the non-motor and psychological impact of Parkinson's and how the OT is part of that treatment along with the other members of the team. So this is just an idea of who we see in clinic really, and the kind of things, the non-motor symptoms that are evident with Parkinson's in everybody that we see. And this is what the literature says. But I would say that people with anxiety and depression that we see here is probably far more than 50%. The majority of people that I see have issues with anxiety and low mood. And we'll talk a little bit about why that might be shortly. When it comes to mild cognitive impairment, just due to the nature of the basal ganglia impairment, then there are cognitive changes, even just being reduced attention and concentration and dysexecutive functioning. Right from the early stages, patients will not realise that those kind of impairments are due to the condition. So information and education around that really straight from diagnosis, I would say, was really important. Obviously, the prevalence of dementia can vary. We will have patients with Parkinson's disease dementia that has come on years after their initial Parkinson's diagnosis, but we will also have patients with Lewy body dementia that is either before their motor symptoms or soon after their motor symptoms are evident. And this is probably due the similar kind of prevalence to that, 30–50% of our clinic patients. And then it's obviously always we need to consider the other issues, the hallucinations and psychosis that happen. Usually maybe due to medication, or medication might be the best way forward with treatment with those. Impulse control difficulties tend to be due to medication. But apathy and fatigue, again, are really issues that the occupational therapists get involved with and are very related to the anxiety and depression. Fatigue being a huge issue with Parkinson's and needs to be managed holistically alongside physio colleagues, managing activity, etc. So really this is looking at the biopsychosocial formulation, the model that we use. So obviously it's looking at the biological thing, the brain pathology. Parkinson's disease is the impairment of the basal ganglia. So there will be biological reasons for a change in cognition, a change in emotion, and change in physical abilities. The change in cognition has a huge impact on patients' daily function. So changes in attention, concentration, language, dysexecutive functioning will have an impact on how patients manage day-to-day activities. For example, I tend to use the example of tying shoelaces. So it's a well-learned task that's going to be impaired on some days. These impairments will have an impact from their emotion. So if a patient is feeling low in mood or anxious about anything, then that will have an impact on how they manage that activity in that day. Patients will also experience low mood due to both a reaction to being given a long-term diagnosis itself that will take time to come to terms with, to accept, and also just due to the anatomy of the brain, the closeness of the limbic system to the basal ganglia, there will be chemical changes, so depression may just be due to that. Anxiety comes along usually due to changes in cognition, the lack of automatic response, the time delay for processing, and unfortunately when we have more time to discuss or to think about what we're doing, we tend to think negatively. When the dysexecutive functioning comes into play, the patients have more time to plan, or planning doesn't happen as automatically as it did previously. And this is where patients can then become anxious purely about coming to appointments or doing everyday activities. Apathy obviously comes due to the loss of dopamine, the reduced amount of dopamine, the reduced drive and motivation. So getting involved with this is really important to look at how we can improve their motivation. Their internal motivators are not there, so it's about looking at external motivation, looking at different things that the patients can put in place to help them with their motivation. So this might be looking at routine, what they do on a day-to-day basis, who else that they have involved or who they've got around them, their support networks, and looking at goal setting, looking at rewards, looking at what rewards they will get for doing different activities, and that sort of thing. So this will all help with apathy. And obviously the physical side of it, the pain, we work closely with the physios. But thinking about fatigue and sleep is an issue for occupational therapists. So looking at a daily sleep routine, looking at their quality of sleep, looking at what pattern of sleep they have overnight, ensuring that they get the best quality sleep, which, if they're fatigued in the daytime due to the cognitive problems, due to the emotional problems, then they're less likely to sleep better at night. So we might need to talk to them about daytime sleep, or routine. It might even be increasing activity. It might be looking at their diet. It might be looking at their fluid intake, but we're looking at their sleep quality as well. So as you can see from this slide, everything is interlinked. So not only are we looking at those three areas, we're also looking at the environmental and social input that they're having. As OTs, we would look at their home situation, look at what environmental issues have an impact on their cognition. Is the environment very cluttered? Is there lots of things around that which means that they are unable to mobilise around their environment as they should? Are they in a house where there is lots of activity going on? Do we need to talk to the carers about, for example, reducing distractions when eating? This might have an impact on their ability to cook food up. What kind of social support do they have? Do they have access to community services such as groups or support groups like the Parkinson's UK groups or any other kind of branch things that are going on that would help them psychologically to come to terms with the condition, talk to other people with the condition, that sort of thing. It's also looking at their function on a day-to-day basis, looking at their work, if patients work, are their workstations, enabling them to work effectively due to their dysexecutive functioning. Are the relationships that they have, both in work, out of work, at home, socially, are they having an impact on how they function? So really, it's about we know, and I'm sure Fiona is going to talk about the importance of exercise activity on patients' function on a day-to-day basis, but the two worst things for Parkinson's are fatigue and stress, both inevitable, unfortunately, but it's about talking to them about reducing this as much as we possibly can. So thinking about what we do for assessment initially, so obviously to gain a better understanding of how the kind of emotional cognition things are impacting on them, we need to assess it fully. So a lot of assessment is around, particularly with cognition, it's around function. How do the patients manage on a day-to-day basis? How are they self-reporting this? How are families reporting this? Getting a good idea of how do they manage. Do they manage their medications on a day-to-day basis, in which case that's a good indication that they're cognitively doing okay. But further assessments might include the MOCA. Now, I know that this has an issue with kind of licensing, but there is a waiver that you can use, or if you're using it clinically, it's worth talking to them on the MOCA people. The ACE3, I don't know if you're aware, is more detailed. It's out of 100, whereas the MOCA is out of 30. So this is a more detailed assessment to give you a better idea of the kind of cognition. And the ECAS is the Edinburgh one. That has a more emotional element to it as well. So they're three really good. So the MOCA can be used as screening, the ACE and ECAS more detailed. And then there are more mood assessments as well. And we have recently started using the PHQ-9 and the GAD-7, which are separate, looking at low mood and anxiety. So they're really good at giving us more detailed assessments of the patient's mood. And obviously we can then compare that with those. Again, there are apathy scales around, there are fatigue scales as well. The Epworth Sleepiness Scale is really useful to use. But again, it's about observation, talking to families, talking to patients about how they manage. So really it's about intervention, and certainly in the Derby team, because we are lucky to have a psychology team here as well as OTs, physios, dietitians, speech therapists. We're looking at a step care model. So this triangular model is around about the lower level, that everybody is responsible for psychological care with patients. And we all, whether, whatever grade, whatever profession, discipline that we are, we have a responsibility to ask and have an impact on their psychological well-being. The next level would probably be the occupational therapists who will look at psychology, obviously holistically. We will look at the psychology and cognition to manage that at a certain level. And then the higher up that model you go, you have the psychologists, the CBT therapists, they have that more specific higher level skills to manage their cognition. So we would usually go through that process when referring to the other members of the team. It obviously is really important to educate the patients about the role of the basal ganglia and why that has an impact on not just the physical, but the cognitive and the psychological impact of their day-to-day activities, and why they struggle with some things one day and not the other. It is really important to find out what is important to the patient, the person with Parkinson's, because different things will be less important to others than they are to some. Different activities, what do they want to do on a day-to-day basis? Those that work, obviously that's important. Those that don't work, what activities are more important to them? So it's really important to look at their own values and what they want. Set goals that are independent to them. The psychological intervention might be around CBT, it might be more acceptance commitment therapy. It really depends on, those are two really good evidence-based therapies for Parkinson's, and that's something that our psychology team use here. But from an OT point of view, literally about fatigue and routine management on a day-to-day basis, thinking about what they do every hour of the day and improving that as much as possible. And it might literally mean using a timetable for them, explaining what activities they can get involved in. Anxiety management, looking about relaxation, mindfulness, how they can reduce their anxiety as much as possible. But again, what's really important is about their carer support and having, looking at who's evolved around them, are the carers healthy, their well-being as well to be able to manage, and what other networks there are around it. And I think I'm going to pass on to Fiona.
Claire mentioned the basal ganglia and why it's really important that the patient understands what's happening and why it's happening. But it's also really important that every member of the team understands basal ganglia, anybody who's working with people with Parkinson's. And it is that impaired performance of really well-learned complex motor skills and movement sequences that goes wrong. And then the ability to multitask can become more difficult, especially the longer they've had Parkinson's. And then a difficulty in shifting motor sets. So that's like changing direction suddenly when you're walking, or suddenly changing a thought process. And normally we can all manage that really easily. We might be in the pub talking about all sorts of different things and somebody changes the subject, but somebody with Parkinson's might start to have more trouble following where the conversation's gone, or they might have more trouble changing direction when the telephone rings. They also will have difficulty with processing questions and information that's been given and need a little bit longer to respond. And that's really important. So for all the members of the team to know that when they ask a question, they may have this mask face, so there might be a blank face looking at them. They need to wait a few extra seconds for the reply, because if you go in and ask another question, they're still formulating their reply, and it will become very confusing if you don't wait. And I think Claire's already explained about how dysexecutive function is associated with basal ganglia dysfunction. So it's that decision-making and planning that becomes more difficult. So because of all of that, the principles of enhancing somebody's function are to get them to pay attention to what they're doing, because it's the automatic movements that are particularly affected, things we do without thinking about them. So people need to concentrate on what they're actually doing, and remember that their ability to concentrate is less than it used to be. And fatigue is much more likely, as Claire's already explained. And then we do all dual task, whatever we're doing, and it's impossible to remove all dual tasking, but it can be worth advising. So it might be that somebody's at risk of falling, So we say don't talk and walk at the same time to reduce that risk. But there are some situations in which case you might have to train dual tasking. And then we use cues and strategies, and I haven't got time to go into those today, but there are lots of places where you can find out about them. But they bypass the dysfunctional basal ganglia, use a different bit of the brain, and actually enable a movement to take place. So bearing all of that in mind, here is the team that you might have around somebody with Parkinson's. And you can see in the green circle there, around the person with Parkinson's at the centre and their carer, you have what we might describe as the core team, the people that they definitely need to see. Almost everybody will need to see with Parkinson's, whereas the ones in the blue are the other ones that they may see or may have different times when they need to see them. The Parkinson's specialist nurse is often the key contact for the patient, often the key worker. If they are lucky enough to have a Parkinson's nurse in their area, then she or he are the people who can usually make the referrals to therapy or coordinate the medication or coordinate communication with the consultant. In many places, there are not Parkinson's nurses, and it may well be that another member of the team or another discipline who's working with somebody with Parkinson's becomes that key contact. So just a very quick overview, because we're time short today, but in terms of managing mostly the motor symptoms, but bearing in mind everything that Claire has said about that biopsychosocial model, we're always thinking about all the motor and non-motor symptoms. But from a physio point of view, we're looking very much at educating the patient and finding and directing ways for support for them and their partner. Exercise is the most important thing to educate a patient about, and physical activity. You might need to be very careful about using the word exercise, and you might need to use activity instead if you don't want to put somebody off straight away. But the evidence shows that exercising, and particularly in terms of endurance and intensity, is really beneficial for Parkinson's symptoms. And then a physio will be looking at gait and balance, trying to reduce falls, looking at posture and transfers, maintaining mobility and strength, and teaching cues and strategies, particularly for freezing, and managing pain. And just in terms of one of the top tips is going to be about transfers on the last slide. So you'll have a tip to go home with. So speech and language therapy is really important as well. And often people don't get referred to speech and language therapy until it's a bit too late. But there are lots of problems with communication. Most people will think about speech and language therapy with swallowing, particularly for inpatients, but communication can become a big issue in Parkinson's, and people's voices softer and quieter. They can help with all the aspects that you can see under that communication list there. And a lot of people, some people will find that perhaps they had a stutter when they were a child, and that comes back when they've been diagnosed with Parkinson's. And the speech therapists have many different ways of being able to offer intervention to support communication. And also swallowing can become more of a risk as Parkinson's progresses for a number of different reasons. And it might just be that it's difficult to get tablets down, or it may be that certain foods become more difficult to chew or to swallow after they've chewed. And then they can also have problems with the vocal fold closure, the presbylarynx, and saliva management. Many patients have problems with drooling or really feeling like they're choking on the mucus at the back of their throat. And then reflux is another issue that you might not have thought of being part of speech and language therapy, but very much is. And again, this is so much skimming the surface. If you want more details, there's lots of places to go for that. When it comes to the dietitian, we're fortunate enough to have one here where we're able to ask her to see people who might be wanting to lose weight or to put weight on. You can have both issues in Parkinson's, but quite a lot of people, particularly if they've had dyskinesia, can lose a lot of weight. They may have other comorbidities such as diabetes and irritable bowel syndrome, which become a bit more difficult to manage with Parkinson's and medications. They might be somebody who needs to redistribute their protein so that it doesn't interfere with their Parkinson's medication. But it's a really important thing to have access to. So if you don't have one in your team or in your vicinity, it may be worth finding out who you can refer to. So we've already shown you a slide with lots of different members. We're lucky enough to have, as Rob said, all of these, apart from the pharmacist at the moment. We have had a pharmacist on the team for the steering groups, but sometimes you find that different team members, you have one and then somebody leaves and then it's harder to find somebody to replace them. But you have so many different elements that you could have in a multidisciplinary team. Your team will look different to somebody else's team, but it's very much about how you communicate with each other. And that's the most important thing. That and chocolate, they both begin with C. So finally, just before we get to the questions, we're going to just give you these tips to take home. They're not our top 10, but they are 10. We might choose other top 10s. There's so many to choose from that it makes it difficult. But these might be something you'd advise the patient, or they might be things that you will use with the patient. So advising them to take a daytime nap, maximum 30 to 45 minutes in the middle of the day. That can really help with fatigue. Advising daily stretches and mindfulness and relaxation, those can really help with anxiety. And the daily stretches can help with hand dexterity. Advising daily cognitive activity to keep the cognitive skills active. Advise reduced multitasking, so that, because that can add to stress, and it can add to something not happening so well. So sitting down when they're dressing, or not trying to do 3 things at once so that they can concentrate on the one thing that they need to do. Encouraging increased physical activity, but you do need to think about those barriers. What's stopping the patient from being more active? What could you do to motivate them? What tips might you give them that would make them more likely to try to do something a bit more and get out of their comfort zone? Use cues such as laser pen, post-it notes, music. And here's my transfer tip. When you want to help somebody who's struggling to get out of a chair, ask them to take off like an aeroplane and not like a helicopter, because of those automatic complex movements not happening, people don't realize that when we stand up out of a chair, we always come forward and up. But when you've got Parkinson's, that process doesn't happen, and they usually try to come up straight from the chair. That's almost impossible. Use your support networks for you, but also you can point patients to support networks, but also familiarize yourself with resources and evidence-based advice. And that means that we can't go without saying, check out the book that's got lots of advice in it. There's a picture of it and the title. Daiga's holding it up at the moment. Because everything we've talked about today is in the book, and everything we haven't talked about today is in the book. So thank you. I think we've just managed it in time, leaving a little bit of time for questions for Daiga.
Brilliant. Thank you, you marvellous 3 from Derby. We have 3 questions, so I'm going to go straight into them. Alistair Mackett asks, he's thanked you for a brilliant talk. And he says, your model is something we would love to emulate, but there are 2 large barriers we have. 1 is clinic space, and 2 is funding for the MDT. How did you overcome those hurdles?
I'm going to let Rob answer in a second, and I would just say that we started without funding. We just had people who were passionate about doing something with Parkinson's, and we were a day hospital for the elderly when we started out, and we started out very small. But if you've got 2 people who are really, really passionate about Parkinson's, you've got a great start. And then you take the evidence to the people that might be the people you've got to ask permission for space and clinics to show them the difference it will make. Rob.
Yeah, and I think, I mean, if you've been watching the news recently, the government's strategy, the new government strategy for the health service, part of it is prevention rather than treatment. So you make your service look like a prevention service. It's community care rather than hospitals. So you make your service look like a community service. So it's sort of, you know, being wise as to where the investment is likely to be, and trying to match your service to fit those criteria. So yeah, as Fiona says, make sure you've got a buddy to an enthusiastic buddy so that you can encourage each other along. The more the merrier, and then include people like managers and commissioners in your group if you can. And that little by little, your service will improve that way.
Brilliant, thank you. Kate O'Kelly from Leicester. Here in Leicester, we have a monthly MDT clinic, which includes an uncommissioned consultant psychiatrist. We are in the process of trying to evaluate our service in order to strengthen the business case. Do you have any experience or tips regarding how best to do this? The data we have is mostly qualitative, and I'm keen for it to be more quantitative, but that's quite tricky to obtain.
Yeah, so we had a grant from Parkinson's UK to introduce a consultant psychiatrist into our clinic, and we tried to collect some data to show that was effective. I think again, like Kate's service in Leicester, a lot of our data was qualitative. So we got feedback from staff and from patients about their experience of seeing the mental health consultant in this clinic. We did try to look at whether there were unplanned admissions with mental health problems, but that data was quite difficult to get hold of. So I'm not sure can you remember anything else we did?
Oh, actually, no, I think it was maybe qualitative.
Move in, Claire, we can't
move in.
Sorry. Yeah, no, I think it was mainly qualitative. It's about patient experience, and also the impact it had on the other members of the team. So reducing maybe work that other team members were getting involved in.
Okay.
One of the definite benefits we find from having a mental health consultant in the team is that they have access to mental health computer systems, which we sometimes don't have access to. So they can very easily say, oh, this patient is open to a mental health service in North Derbyshire or in East Derbyshire or whatever, and be able to find out what the last treatment plan was from the mental health records. So that is a really practical thing that they add, and maybe putting that kind of describing that experience in your report is helpful.
Excellent.
It was also really helpful to finalise and define more our pathways for cognition and mood. That was really good.
Excellent, thank you. There are a number of questions. I'm going to ask one more live, and then I'll ask you to go into the Q&A and that. So my last live question is from Deborah. It was mentioned about PD nurse assessment at the newly diagnosed stage. Are there physio and or OT proactive assessments, or is this covered in the education sessions?
Can you just repeat the end of the question? You broke up a little bit there.
Sorry, are there physio and OT proactive assessments, or is this covered in the education sessions?
In terms of finding out how active the patient is, or we have documentation that we use as assessment starting points for OT and physio, and we're able to, through those assessments, pick up other issues that might be going on for the other members of the team. But we have pre-prepared assessment sheets that address how physically active are you, what are you doing already. They're very comprehensive to find out as much as possible. We have an hour with a new patient, so plenty of time to get to the bottom of things.
Brilliant. Thank you for your time this afternoon. As I said, there's a number of questions. There are 10 open questions for the three of you to dive in and see if you can answer. Thank you very much. Cheers.
Thank you.
Thank you.